Within this series of videos, you'll learn about behavioral assessments for obesity risk factors. We'll also discuss how to incorporate these behavioral assessments into our development of treatment plans for individuals in need of support. We have 3 learning objectives for this series of videos. By the end of this series of videos, you will be able to interpret a comprehensive weight and lifestyle inventory to determine appropriate targets for intervention, identify the strengths and limitations of different measures of physical activity, and identify the strengths and limitations of different measures of dietary intake. This video will focus on our first learning objective, which is to interpret a comprehensive weight and lifestyle inventory to determine appropriate targets for intervention. We know the causes of obesity are complex. For any given individual, there is usually not just one simple cause of their weight status or obesity, but rather many factors that may interact and contribute to the development and maintenance of obesity. To fully appreciate this in research and practice, we need to employ comprehensive assessment strategies to ensure that we are fully understanding each individual's unique combination of behavioral risk and protective factors. By applying these comprehensive assessments, we can better tailor our intervention approaches. The Weight and Lifestyle Inventory, or WALI, is one example of a comprehensive assessment of weight-related behaviors and obesity risk factors. It was developed and is designed to be used in an obesity treatment clinical setting. We'll learn more about the WALI as an example of how to conduct a comprehensive behavioral assessment to understand causes of obesity and related health problems. The items in the WALI cover 4 main themes of behavioral risk factors, summarized by the BEST acronym. These themes of behavioral risk factors include biological factors, environmental and behavioral influences, social and psychological status, and the timing of present weight loss efforts. Let's review each of these themes and the items that correspond to each theme to provide you with a better understanding of the rationale for what is assessed in the WALI and how each theme provides clues for treatment. Biological factors include factors that suggest a biological basis for the individual's weight status, as well as a biological propensity to gain weight and maintain a higher weight. These factors are assessed by the WALI items that assess age of obesity onset, weight history, how many times the individual has tried to lose weight, their success during these weight loss attempts, and their propensity toward weight regain, and their family history of obesity. All of these items provide important clues for treatment. All can suggest that the individual has a genetic propensity toward obesity, meaning it may be harder for that individual to lose weight and maintain the weight lost. These items may also suggest that the individual is prone to having a larger body due to their specific genetics and early life experiences. These items can also give us a sense as to how reversible the individual's weight gain and weight status is, which is encompassed within the ideas of hypertrophic versus hyperplastic obesity. Let's take a minute to define these terms. To understand how different types of obesity may be more versus less reversible, we can distinguish between hypertrophic and hyperplastic obesity. A healthy weight individual has a certain number of fat cells. If that individual gains weight, the size of those fat cells increase. This initial weight gain is fairly reversible in that an energy deficit would result in a reduction of fat cell size, and this individual could feasibly return to their starting weight. This first level of obesity, which is caused by an increase in fat cell size, is called hypertrophic obesity. However, as obesity worsens and an individual's weight status moves into the higher classes of obesity, the fat cells reach their capacity and positive energy balance begins to result in the development of new fat cells to store the extra energy in the body. So when an individual has hyperplastic obesity, they have both larger fat cells and an increased number of fat cells contributing to their higher percent body fat. This is less reversible because fat cells can decrease in size, but they do not go away once created. Therefore, an individual who has reached the level of hyperplastic obesity can lose weight, but likely cannot return to their starting body weight because of their increased number of fat cells. We don't have a definitive measure for when an individual's obesity is due to hypertrophic versus hyperplastic reasons. But two solid clues are their level of obesity and how far they are above their ideal body weight. These data presented in this figure illustrate this association. This study examined the association between how far participants were above their ideal body weight, represented here on the x-axis, and their estimated fat cell number, represented here on the y-axis. Each dot represents an individual participant's data. We see a trend where people who were at or a bit above their ideal body weight had a fairly consistent number of fat cells. However, when we get to participants with body weights that were at or above 200% of their ideal, or 2 times higher or more, we see that the number of fat cells increases with increased body weight. So, if the respondent indicates that they had an early age of obesity onset, a long history of higher weight status, many failed attempts at weight loss, and a family history of obesity, all of these suggest that this individual has a higher genetic and biological propensity for obesity. This knowledge can then be used to tailor your counseling messages and treatment goals. One thing we would want to convey to these individuals with higher genetic and biological propensity for obesity is that their genetics and biology are partly to blame, but they shouldn't feel bad about their weight and experiences because they can still celebrate healthy changes even if they don't result in major weight loss. We would also want to make sure that our weight loss targets are realistic and that we appreciate that a healthy weight for this patient may be different than for other patients. Finally, we would want to emphasize how weight loss of as little as 3 to 5% of their body weight can produce meaningful benefits for improving metabolic health. So, focusing on small goals and the things that the patient can control can go a long way towards supporting sustained motivation to change health behaviors. Environmental and behavioral factors include eating behaviors, exercise patterns, and other environmental cues that may influence the individual's energy balance. These factors are assessed by the WALI items that assess the respondent's meal and snack patterns, diet composition and quality, appetite, problematic eating behaviors such as binge eating and night eating, physical activity patterns, and environmental factors that influence these behaviors. All of these items provide important clues for treatment because they highlight modifiable factors that may be contributing to the individual's obesity. Therefore, our review of these items can help us work with the patient to figure out a diet or exercise plan that they would be most likely to adhere to. These items can also highlight ways that the patient can change their environment to be more supportive of changing their health behaviors and working toward weight loss. These items may also highlight additional needs the patient has that can be addressed through referral to a different health professional, such as a dietitian, a personal trainer, or a therapist. So if the respondent indicates that they have high frequency of meals or snacks, their diet quality is low and comprised of high energy density foods or other sources of calorie surplus, a large appetite, problematic eating behaviors, or low physical activity levels, this knowledge can then be used to tailor your counseling messages and treatment goals. We would first want to emphasize the things the patient is doing well. We would then want to emphasize that many of these factors are modifiable, which is promising because it means there is a lot that is in the patient's control. We would want to work with the patient to highlight behavioral changes that may improve health, physical activity, and other health behaviors, and determine which of those are the highest priority for the patient and that they feel are the most feasible sources of change. We would also want to take this opportunity to identify environmental and other supports for behavior change. Social and psychological factors include factors related to the patient's mental health and social networks, which may influence their health-related behaviors and ability to participate in a comprehensive lifestyle program. These factors are assessed by the WALI items that assess the social context of weight loss, for example, whether there are people who would support weight loss efforts versus serve as a barrier, desired changes in social support for weight loss and health behaviors, psychosocial effects of obesity, such as how satisfied or dissatisfied the patient is with their weight, the presence of mood disorders such as anxiety or depression, and substance abuse or dependence issues. All of these items provide important clues for treatment because they highlight factors that may either support or detract from an individual's ability to engage in behavior change and weight loss efforts. If a patient has untreated mood disorders or issues related to substance abuse or dependence, then that patient should be referred to a psychologist or psychiatrist first to work through these issues. Issues such as untreated depression can make it very hard for a patient to engage in other forms of treatment, so it is important for the patient to get help with these issues first before enrolling in a weight management program. In addition, these factors can help us understand who in the patient's social network may make behavior change more difficult versus who the patient can lean on for support. So, if the respondent indicates that they have an unsupportive social network and desired increases in social support, high body dissatisfaction or low body esteem, mood disorders or substance abuse or dependence, all of these provide us with directions for tailoring our counseling and treatment approaches. We would first want to refer patients who need help from a therapist to prioritize our treatment efforts. We could then work with the patient to identify ways that they could harness existing social supports or form new social supports for their weight loss efforts. If the patient is experiencing a lot of negative psychosocial effects of obesity, we may also want to help them improve their body esteem and promote appropriate perceptions of success and realistic weight loss goals. At the end of the WALI, there is a section that assesses whether this is a good time for the participant to engage in a comprehensive lifestyle program. These factors are assessed by the WALI items that assess the patient's current levels of stress, major life changes, perceived time available for weight loss efforts, and confidence in their ability to change. These all help us understand why the patient wants to try to lose weight now, and whether or not this is a time when they can be successful at focusing on their behavior change and weight loss efforts. These items can also highlight the participant's stage of change, commitment to change, and ability to change. So, if the respondent indicates that they have high levels of stress, they are undergoing major life transitions, they have little time available, or they have low confidence in their ability to change or readiness to change, these all provide us with directions for tailoring our counseling and treatment approaches. If it genuinely does not seem like a good time to attempt a comprehensive lifestyle program, then we can suggest the patient start at a later date. We would also want to counsel the patient regarding how to maintain their current weight in the interim. For patients who have the time to change, but not the readiness or confidence, we could engage in motivational interviewing to increase their readiness to change and their confidence. Now that you have a better understanding of a comprehensive behavioral assessment like the WALI, let's talk about how this would fit in when we are doing a behavioral assessment and intervention with individuals who would like to or need to lose weight. We can break down our approach into 6 steps. First, we would want to have the patient complete assessments prior to their appointment with us. Next, we would initiate the appointment, and after an acclimation period, initiate weight loss talk. We would then engage in the best assessment, where we would review our comprehensive assessment with our patient to better understand their lifestyle factors and weight loss goals. We would want to reflect and summarize our time with the patient, and then work with the patient to develop a treatment plan. Before the initial appointment, you would want to have the patient fill out necessary assessments such as the WALI or perhaps other assessments like a depression inventory or other diet and physical activity assessments so that you have data to review during your meeting. At the beginning of your time with the patient, it is important to take 5 to 10 minutes to get to know them. You can ask about their social ties, their satisfaction with work and leisure, and their current life goals. You want to build rapport and ease your patient into the appointment. Next, you would want to broach the topic of weight loss by using open-ended questions and gateway topics, such as, how are you feeling about your weight right now? I see your glucose levels are high. Did you know losing weight could help with this? You would want to avoid confrontation or leading questions. You would then review the patient's WALI or other assessments with them to identify the best factors to target within your intervention efforts. You should be sure to review the patient's strengths and barriers and identify modifiable behaviors that seem like feasible starting points for behavior change. After reviewing the assessments, you would want to be sure to reflect and summarize, to recount with the patients your findings from your BEST and other assessments. Provide ample time for questions and discussion from your patient, and be sure to clarify goals for treatment. And note that these goals may be behavioral or they may be weight loss focused. You would want to emphasize that both behavior change and weight loss of 3 to 5% of the patient's current body weight are great markers for success. Finally, the assessment findings should inform the treatment plan. The intensity of a treatment should match the level of obesity and the reversibility of the obesity based on the clues you have from your assessments. A great guide for developing this treatment plan is the 2013 Joint Guidelines for Management of Obesity. Let's pause here and review some key takeaways. Obesity is a complex condition that merits comprehensive assessment. The weight and lifestyle inventory is one example of a comprehensive approach to assess and understand influential factors. Careful review of behavioral assessments should guide our choice of treatment methods. Findings from behavioral assessments can inform whether the patient desires individual versus group treatment, what lifestyle changes may support weight loss, whether the patient is a good candidate for pharmacology or bariatric surgery, and whether other specialists are needed. That's all for this video. Thank you for learning with me.